Hello, everyone. It sounds good to say that again after our break. So today we're going to do an episode that means a lot to us. It is one of our major research interests, and that is misophonia. This might be something you have never heard of, or this might be something that you have, and you may not have gotten to hear very many podcasts on this or read many articles because the research is so new. And this condition has been ignored for so long. And that is why I'm really excited to do this podcast episode. Our guest today is our advisor, Dr. Zach Rosenthal. And he started the Center for Misophonia and Emotion Regulation, where Kibby is a postdoc and I am a grad student. And we have an entire research center devoted to misophonia research. And it's been so gratifying to do this research because the participants are so enthusiastic. They're so grateful because this has been ignored and invalidated for so long. And one thing that I find is that people with misophonia, they think they're alone, and they haven't even realized that there's so many other people struggling with this too. So we'll have Zach come on and tell us what exactly misophonia is, tell us about the research and treatment, but just briefly, I'll sort of say casually what misophonia is. So misophonia is when people get extraordinarily bothered by certain sounds. And those sounds are typically mouth or nose sounds, but the number one trigger that I hear about is chewing. So if you know someone in your life who just gets enraged or just panicky or incredibly irritable and frustrated when they hear you chewing or someone else chewing, you might be dealing with misophonia. There are other trigger sounds, often sort of low-level repetitive sounds like shuffling feet or the hum of the air conditioning or pen tapping, just things like that. They can also be trigger sounds. But chewing is probably the most prominent sound.
I can't wait to ask Zach a little bit more about how do we know if there's like a misophonia problem or if it's just kind of like a normal reaction. Because I don't know. I don't think I have misophonia, but I can remember sitting in class, taking an exam, and a person next to me having a cold, and they like sniffle every few minutes.
Those get me too.
Yeah, you know, and then you're just like, oh, you know. So in those contexts, in those situations, I've felt anger, but that's not a typical feeling that I have every time I hear someone sniffle. So I'd love to hear, I'm going to ask him a little bit more about that.
Yeah, exactly. I think a lot of people, they hear this and are like, oh yeah, I hate the sound of chewing too. And it's like, well, is that misophonia or isn't it? So yeah, we'll have him shed some light on that as well. This is something that I've had experience treating, and it's been really cool because we do have a treatment study. We actually have multiple treatment studies going in our lab at the moment. And it's really given me a lot of insight into the struggles of people with misophonia and their family members. You know, this is a condition that can be devastating for the individual with misophonia, but it's no walk in the park for their family members either. So, you know, we'll have Zach on to talk more about the struggles of the person with misophonia. But I can tell you, you know, I've assessed people who can't go to work at normal hours. They're working night shifts because the sounds of the office or the sounds of people eating lunch are just too agonizing for them. They can't eat meals with their family, and so they spend so much time alone just trying to stay away from these sounds, not only because the sounds are so painful to them, but also because the way they react to the sounds is so shameful and causes so much disruption in their relationships. And so I think this is actually a really important episode for those of you who have loved ones with misophonia, because it is a struggle for you as well. What often happens is that the person with misophonia is particularly bothered by a sort of set of like really close people in their lives. This doesn't always happen. A lot of people with misophonia are bothered by absolutely every person who chews, but it's just something that I hear over and over again. Most common culprits seem to be parents, spouse, and dog. Dog is a little bit lower down the list, but you can imagine the kinds of mouth sounds that they make. But parents and spouse are huge, and what often happens is, the spouse is eating lunch or snacking, and the person with misophonia has this just wave of intense anxiety and anger. And it's a fight or flight response that happens. So they'll either try to run out of the room, or they might fight and snap at you, insult you, mimic you. All of these things are really hurtful when you're just doing something as simple as eating. And nobody likes to be a source of anger, and especially disgust. And so that's a really difficult position to be in. And I want to recognize that for those of you who may have a loved one with misophonia, that is a really painful way to feel. And the person with misophonia also feels immense shame and guilt. I mean, this is one of the number one things that we work on, is the emotional reaction to having these triggers, not even just the momentary trigger. It's, why did I yell at my spouse? Why can't I just have a simple meal with my family? Why did I make my husband feel like garbage for just eating? And, from the spouse's position, it's like, I don't know how to eat any differently. Like, am I disgusting? Am I eating in a really strange way? And I guess, first of all, I would just say, if there's any way to try not to take it personally, this isn't about you being a strange eater or a disgusting chewer. It's much more about an attentional fixation. And it's actually really cool looking into the disgust literature, because what we know about disgust is it's a reaction to a potential threat, but it's not the kind of threat that produces a fear response when you want to notice it and then run. It's much more like, wait a minute, I need to pay attention to this because this food might be diseased. And so it can really fixate your attention on that object. So you really figure out exactly what it is, and you're looking at it really closely. And that can then increase your emotional reaction to it, right? Because you're engaging with it so much. And so attention can be a really interesting component of misophonia as well. Kibby, do you have any suggestions for what a couple can do, or a child and a parent can do, with this dynamic of, I just want to eat a normal meal and you're yelling at me?
Oof. I mean, I think this is what we're trying to do research on, right? Just trying to understand, how can this be helped, and how can loved ones support that? And I think that the natural tendency would be for the loved one, like the spouse or a friend or, family member of someone with misophonia, would then try to, if they're even trying to be helpful, they will try stop chewing around them, or try I've seen people only eat non-crunchy food around the person with misophonia, or just really help them be on guard and try to avoid those scenarios, eating somewhere else, or and I think that either is just showing support in general, so I don't think that's bad, but I mean, we always go to validation, right? We always go to validating their responses. And, but without understanding what this disorder is, it's hard to know what loved ones can do. So, as you said, not taking it personally, validating that it's a real thing, that they're not just acting out of, at you and creating conflict at you, but it is this physiological, they just fly into a rage when they can't help it. So just understanding that that's... Yeah. It's almost kind of like an allergic reaction to something, right? We know that that's not someone's fault or choice. It's just something that their body's doing and they're reacting to. So even just keeping that in mind will help guide the next steps, or what you do and say to that loved one with misophonia. But that's all I got. This is real. This is open playing field for research,
Yeah, I mean, that really is how it is. We want to be able to come here and provide all the answers, but the reality is there's just so much that we still don't know. The good news is that I've just seen a total proliferation of this research, and there's a lot of enthusiasm around it. So I like to think that help is on its way. And I know we're doing what we can to help. I mean, we're developing treatments or seeing how kind of existing treatments can be applied here. And I've treated misophonia, and I think it actually went really well. I've done Zach is going to tell us about the multiple treatments going on in our center that we're looking at, and one of them is called the Unified Protocol, and that's what I've been trained in yeah, I think there's a lot of promise with it. What I can tell you about the treatments that are happening is, we don't want to overpromise at this point, but so we don't want to say like, okay, if you do psychotherapy, you're never going to be bothered by sounds ever again. But what we are trying to do is kind of help you change your approach to these sounds, maybe be able to react in different ways, and then therefore mend some of your relationships, strengthen your own sense of, actually, I can get through this, and I can get through the day, and I can hear these sounds and not fall apart. And so we're really kind of bolstering the emotional reality around misophonia. And I've seen that to be quite powerful. So I'm hopeful that will continue.
Sounds like giving people with misophonia agency over,
right?
So they don't just feel helpless and trapped when they're sitting with someone who's chewing, but they actually they have some tools and skills to be able to kind of manage the way they're reacting to it.
Yeah,
that's cool.
Exactly.
I'm excited.
Yeah. So let's bring in Zach now. So Zach is a clinical psychologist. He is still practicing, so he's seeing patients and doing research. Again, he founded the Center for Misophonia and Emotion Regulation, and he's a professor at Duke University Department of Psychiatry. All right, we'll go into the interview. With us today is our favorite guest of all time, obviously, because he is our wonderful advisor and misophonia expert, Dr. Zach Rosenthal. Zach, thank you so much for coming back.
Oh my goodness. You have to have better guests if I'm your favorite.
But not ones that we love more.
Okay, where to go?
So a lot of pressure.
We're not going to go. It's a lot of pressure. We're not going to go anywhere with it. We're just going to keep rolling. I'm glad to do this for you all.
Zach.
Thank you for having me. Happy to be here.
So Zach started the Center for Misophonia and Emotion Regulation, where Kibby is postdoc. I am a grad student, and we've been doing a ton of awesome work. So obviously this is something that Kibby and I can both speak to, but Zach, really being the expert, really appreciative of you being here. Can you just start out by kind of explaining to us what misophonia is?
Sure. So misophonia is a term for a pretty new condition that some people call a new, quote, disorder. Other people might call it a condition, but it nonetheless is something that's pretty new to the clinical world and the research world. And what it is a condition that is characterized by decreased tolerance to specific sounds or the cues that are associated with those sounds. And the easier way to say it more kind of plainly is people who get easily triggered by things like chewing, crunching, sniffing, snorting, sneezing, coughing, throat clearing, a lot of different oral or nasal sounds that are repetitive and that trigger a strong reaction physiologically and emotionally and cognitively as well as behaviorally. And the kind of way to think about that strong reaction in some ways is to think about it as irritation, anger, anxiety, or disgust. These are the four kind of primary reactions that people have with misophonia when they're triggered by these different types of trigger sounds.
So especially when we talk about misophonia with people, a lot of people can identify with hating a sound, right? Like, oh yeah, I hate the sound of nails on a chalkboard, or the sound of chewing really irritates me. But how do we know the difference between someone who just doesn't like sound, which seems to be common, and misophonia in a way that may be like a mental disorder, a psychological disorder?
Yeah, that's a really good question, Kibby. So, you want to think about it this way, that lots of people, as you said, have negative reactions to things that are gross or disgusting or just noises or sounds that others make. That's ordinary. That's normal. Misophonia is not just easily being triggered by these types of sounds and associated cues and having those reactions. In addition, it's having really significant life impairment because of these triggers and their effect. So the person with misophonia is different than the person without misophonia who doesn't like these sounds because the intensity of the reaction, number one, is much stronger. But probably even more importantly, what makes misophonia a problem is that it's functionally impairing, meaning it's getting in the way significantly of day-to-day functioning, home, with family, with friends, with kids, coworkers, et cetera, et cetera. And that is what makes it more of a sort of dysfunctional kind of problem versus just a thing that someone doesn't like. And you can think of it on a spectrum. Think about a spectrum. There are some people that have really, really extreme reactions and are very, very, very impaired, can't work, can't sit at the table with their family while they're eating, can't be around people in public. The real extreme reactions that are incredibly impairing. And then there's people on the other side of the spectrum that are mildly bothered by these kinds of sounds, easily triggered. They don't like it, but they don't have real significant impairment. They're going to school, they're eating with their family and friends, they can be around their partner, and yeah, they don't like it, but they're not angry, they're not escaping or avoiding, they're not getting confrontational. They're kind of just noticing there's something happening that they don't like. That whole spectrum is the way to think about it. And the more you get to the severe side of the spectrum, obviously, the more problematic it is. And at some point on that spectrum of severity, as you move closer to the severe side, that's really where you start thinking, okay, this is somebody kind of, quote, with misophonia, as opposed to somebody who's just mildly bothered and maybe has some features, but isn't best characterized as having the condition.
I've been really struck doing this research by, first of all, before I met you, I'd never even heard the term misophonia, and I didn't know this existed. And that's a very, I think, common reaction, and why it can be so invalidating for patients as they go to therapy and the therapist has never heard of this, has no idea what to do about it. And yet, when we start researching it, there's so thousands of people signing up for our research studies, really enthusiastic. It's like they've been desperate for help for so long. Why do you think that this condition is only just now coming to light, or only now getting attention?
Awesome question, Jacqueline. You know, the term itself came about in 2002, the formal term misophonia. It's a new term, and it came about in the clinical literature, not in the scientific literature. And in the clinical literature, and frankly, in the scientific literature, lots of times things that are new don't really make it to the public. They don't really make it into the kind of limelight of the public in a way that people will know about. So it takes a while. It can take a while for a newly named phenomenon to go from obscure clinical journal, new name, to something that doctors and clinicians are assessing and have expertise in. It takes a while. One of the ways that I think this has accelerated in recent years for misophonia is that the New York Times did a piece in 2011 that really started putting misophonia into kind of the lay public's minds. And since then, there have been many, many articles, podcasts, stories online. There's been a documentary called So Quiet about misophonia. And there's really now, even online, if you start looking on TikTok or YouTube or any of the online channels on Instagram, you can start seeing there's a lot more visibility to the term. And as the public becomes more aware of the term, they start asking themselves, is this something I have? And it turns out we don't know for sure what the prevalence is, but the data we have suggests that somewhere between 12 and 20% of people report having moderate or higher impairment in their life caused by these kinds of triggering experiences to mostly oral or nasal types of sounds like the ones I described earlier. So there's probably a lot of people out there that experience this but never had a word to label it. And so now that the word is out there and the word is becoming more and more out there, I think more and more people are realizing, wow, This is a word, and these are symptoms that actually characterize like my experience. This is a thing. This is real. And when you go from suffering quietly, shamefully, in isolation, believing that what you have is just you, maybe you're broken, maybe there's something wrong with you, you've got horns growing out of your head, but everybody else doesn't. When you move from that space psychologically to one of, wow, this is a thing being written about, this is a thing being studied, this is a thing that there are podcasts about and there are articles about and so on, it's very, very validating. It's incredibly validating. It makes it really feel like, okay, I am not the only one. I don't have horns coming out of my head. This is the thing, and this is real.
Can you paint a picture for us about what this would look like, maybe from a typical case that you see, or an example, something to kind of give us a better sense of the situations and the behaviors and what happens, but also like the internal experiences of people with misophonia?
Yeah, absolutely. So there's a lot of different ways this might come about and a lot of different ways this could look. But I'll give you a prototype, kind of a general example, understanding there can be all sorts of differences, right? But a general example is you might have someone who typically sometime around the ages of 10 to 12 starts noticing that they are having these strong reactions to other people eating or chewing or drinking or swallowing or sniffing or any of these kind of oral or nasal noises. Again, this is a prototype. And they're a kid and they start noticing this and they can't do anything about it and they're having these strong negative reactions. And then it keeps happening and they feel stuck. They feel trapped and it keeps happening. And these are kids. So they're in these environments with people that are producing these really aversive noises that are essentially grating on their nervous system, triggering them as though there's a grizzly bear in the room with them. And so their nervous system is getting activated, but they can't escape. And so then over time, they begin, as you would if there was grizzly bear in your room in random places, you begin noticing signs and triggers for the possibility, anticipating with vigilance that there might be a grizzly bear coming. So the same kind of process might be happening with these kids as they start getting more vigilant, more anxious, more nervous, more careful, and trying to avoid or escape from these types of triggers, because who would want to feel that way? So then over time, you can kind of envision this over years. There's a lot of avoidance, a lot of escaping, a lot of just like clenching your fists and tolerating and dealing with it, white knuckling it to get through a situation you can't escape. And then keep going over time as this child is now, a teenager and a young adult, they've probably learned to develop some coping strategies for how to cope with this. And some have developed some skillful coping strategies. Some have developed some not so skillful coping strategies, and some both. And this is where it's likely that we might start to see problems with psychopathology or other kinds of like psychological or mental health related problems. They might emerge on the heels of trying to cope effectively with misophonia. So if you're really anxious about being triggered as a teenager, over time, that anxiety might generalize and now become more generalized in general to not just misophonia, but to all sorts of things. And now you might end up with a diagnosis of generalized anxiety disorder, or maybe a panic disorder, or maybe it's some other disorder. There's no particular psychological, psychiatric disorder that we know is linked to misophonia. Misophonia is linked to a wide variety of different disorders. It does not appear to simply be just another disorder. But what then happens, again, you have this person who, as a prototype, now is easily triggered, has some functional and some dysfunctional ways of coping, but they're really struggling. They go to school and they can't focus. They can't eat around their friends. They can't eat around their family. They can't be around their family. They can't take vacations and be in the car with their family. They do not want to be on the airplane because we know in the airplane you can't get out. And there's people eating chips or eating apples or what have you. There's all sorts of potential triggers. Don't put me on an airplane, right? So, so all sorts of things that otherwise one might do for fun, the person with misophonia might look at as a source of potential triggers and therefore escape or avoid. They don't want to deal with it. It's not worth it. Right? And why would it be, right? Why would you want to show up with a grizzly bear attached to you if you don't have to? This over time could look like difficulties with relationships. As kids, it starts with the kid who has a hard time being around family members. And again, this is all prototype. And it might also be that family members sometimes don't have the best strategies or tools to help the kid. Not because it's not their fault necessarily, but they may not really have the best tools to help manage this. So you can see there can be a pretty transactional type of problem here where a fit between parents and what they're capable, or caregivers and what they're capable of doing in terms of managing their kids' stress and anxiety and such related to misophonia, if that's not a good fit with the temperament and the biology and the experience and the behavior of the child, things could look like not a great relationship, right? And this could lead to difficulties with attachment. This could lead to difficulties with understanding who to trust, how to trust. Oftentimes, again, prototype, oftentimes these are family members that are the primary source of the trigger. So in this kind of prototype I'm drawing out, it might be that dad is the trigger or mom is the trigger. And so how do you have a functional, good relationship with someone who is this intense trigger of anger and irritation and disgust? And you're not making it up. It's stuff happening in your body and in your brain. It's conditioned, possibly learned, possibly drawn by kind of underlying biological vulnerabilities across various neurobiological systems. Point being, it's a real thing, and you can't necessarily just control it, and you're certainly not wanting it or being manipulative or anything. It's just a thing that you're struggling with. But now you've got this parent or parents or whomever in your family that it's just really hard to have a strong relationship with. Keep going over time, and you can see how that could translate into hopelessness about relationships, depression or anxiety, difficulty being willing to meet people, to develop relationships. Patients that I have that are in that kind of early adult phase of life with misophonia, they often just tell me, I'll never have a relationship. It'll never happen. That's what they believe. It may or may not be true. In most cases, it probably isn't true. But their thought, their belief, it's hopelessness, right? They believe that they can never have this because they have misophonia. I could go on and on. There's a lot of different ways, but you can imagine if the place that is supposed to be safe, a place of trust and nurturance, if that's a place where you have grizzly bears, if that's a place where there is this kind of anxious arousal and difficulty being easily triggered, it might be difficult to be able, A, to cope with that and develop good coping skills, B, to have good relationships without having some help and treatment and such along the way to help overcome it.
Real quick, do we know why these sounds, and do we know why the misophonia often attaches itself to a few close people in your lives?
We don't know why these sounds. Most people with misophonia do report oral or nasal sounds as among their primary triggers, but there are a really, really wide variety of different types of sounds. Most of them are human-made by others, but some are not human-made. They might be clocks ticking or things like that. So there's not just one sound, but there does appear to be sets of sounds, oral or nasal sounds. So there's different ideas about this, but we don't actually know. We don't actually know if it is something that has to do with the hardwiring of the brain around oral or nasal sounds. We don't know if it has to do with, perhaps evolutionarily speaking, there may be a certain sensitivity to certain types of oral or nasal types of stimuli. These are ideas people are sort of cooking up, but we don't know for sure.
Okay.
It's really interesting to also get to know this disorder and like the way it affects families and everything like that, and also the role of knowledge, knowing what it is. Because I remember as you were talking, I was thinking about someone I met who has a little bit of misophonia, and she said that she couldn't sit at family dinners, and everyone thought that her family thought that she was making it up or just being an angsty adolescent and just storming out. And when she would explain that it was the sound, people said, "Oh yeah, of course there's sounds. Like that's annoying, but you know, you don't have to get up and leave." And even not knowing her own experience was really, it created a huge divide between her and her family. So that affected her personality, her identity, her feeling of belonging, until her family got to know what it is. So it's just, that knowledge is huge with the relationships.
I couldn't agree with you more, Kibby. It's like when you have knowledge about what might be going on, it's kind of like the glue that takes what feels fragmented and pulls it together into one organized piece. You know, it's a way of saying, okay, this is real. This is a thing. I'm not crazy. I didn't make this up. They're wrong. They're oversimplifying it. It's actually hard and it's a real thing and I'm not alone with it. And that's just an extraordinarily powerful thing.
Along those lines, I mean, what can family members or friends do for the misophonia sufferers in their life to help?
Well, as Kibby just pointed out, probably the most important first thing they can do is be supportive and validating.
Mm-hmm.
Leaning in to understand and be curious rather than presuming that there's some sort of manipulation or some sort of something else going on. But really, the first thing is listen and love and lean in. Right? Listen and love and lean in. That would be number one. And number two would be then think about how can you help this person connect to resources that provide the type of psychoeducation as Kibby was just describing, right? There are places like our center and others where you can go online, you can start reading and realize this is a thing. I can't tell you how many times people have come to me in the last couple of years since we opened up our center at Duke and said, I didn't know this was real. And then I started reading about it. And oh my gosh, it is all making sense. This is actually real. I'm understanding it. So getting people to those resources of education really will help them move from feeling less like a human to more like a human, from being totally fragmented to being more coherent and less fragmented, from feeling like they don't have any insight about why things happen to having a bit more insight. And insight is essentially the ability to predict and to control and respond effectively to the world, right? Knowing what's likely to happen, knowing why, and knowing what you can do. That's insight. So education can build insight, and from insight can come this sense of self-empowerment, self-regulation, and the ability to then communicate to other people about what they've got going on and what their needs are. And then, of course, the third thing would be to get treatment. And in general, a treatment strategy is to look for a multidisciplinary set of treatment evaluations and recommendations as the starting point. So see a psychologist, but don't cash in all your chips on a psychologist. Go see an occupational therapist for an evaluation, but don't necessarily cash all your chips on them. See an audiologist for an evaluation, but don't assume the audiologist has all the answers. This is a multidisciplinary problem that is best attended to, I think, by a multidisciplinary set of solutions. So seeing the OT helps you with sensory problems. That's what OTs do. They're the sensory people. So you see the OT, the occupational therapist, for an evaluation, and they're going to assess objectively, quantitatively, your whole sensory functioning across all of your senses. And that matters because we live in a multi-sensory world. We don't live in a unisensory world. We don't live in a world where you just hear or you just see, right? We live in a multi-sensory world, and all of our human experience is filtered through multi-sensory processes. And the OTs are the people that are the experts in that. We psychologists, we're not the experts. They are. So go see an OT for an evaluation. And even if they're not experts in misophonia, what you do is you say, I need an appointment for auditory sensory over-responsivity, auditory overreactivity. I'm having difficulty in my life functioning at work, at school, or my kid, if it's a kid you're calling for, difficulty functioning, right? You don't have to use the word misophonia. Describe what's going on with it and ask for help with an evaluation. You'll get the appointment if you do that. You might not get the appointment if you say, I have misophonia, can you evaluate it? Same thing with the audiologist, same thing with the psychologist. Then you start from there, you've got this multidisciplinary set of evaluations with recommendations for treatment. And there what you can do is you're empowered to decide what it is that makes the most sense to you, what you're willing to do, what you think addresses the parts of misophonia that are most impairing and most distressing to you. And then you get started and you go for it, whatever that might be, for each or all of those different treatment approaches. And by the way, you could also see a psychiatrist or a neurologist, a neuropsychologist. There are other disciplines. I'm not limiting it to those three. I'm saying as a starting point, that's probably where I would recommend most people start for evaluations.
Oh, I have three more really important questions.
I can be quick. I promise I can also answer quickly.
Well, okay, so basically my three questions. I was obviously hoping you would dive into treatment, and that's the number one question that people with misophonia have. Have there been advances in treatment? I mean, can you look at a person with misophonia and say there are treatments that we know work, or there are treatments with promise, at least in this psychology realm?
In the psychology realm, we can say there are treatments with promise. They're all of the family of what we call cognitive behavioral therapies, plural. They're not one specific protocol. It's really a family of therapies that are called cognitive behavioral therapies. And a number of different researchers have begun testing CBTs. And so if you go into it thinking a CBT provider is probably, at least from an evidence base, going to be able to provide a treatment with the most promise. The particular specific CBT interventions that have been studied, they actually vary quite a bit. There's a lot of different ones being experimented with. But generally speaking, that would be the angle to take. In other words, there's no data to suggest that general supportive therapy alone is the best approach. And there's no data to suggest that something like a client-centered therapy is the right approach, or a psychodynamic or a psychoanalytic. There's no data. It doesn't mean those couldn't be helpful. They might be, but there's no data that's ever been evaluated or presented to show that these are indicated. So generally speaking, a CBT model is probably your starting point. Yeah, that's probably the shortest answer to it, Jacqueline.
You could put in a plug for the kind of research that, kind of studies that we're looking at and treatments that we're considering too.
Well, we're looking at a couple of different things in our group at Duke. Two of them are psychotherapies that are in the CBT family of treatments. And one of them is a neurostimulation intervention that our colleague, Dr. Andrada Nekshu, is studying. So for the latter intervention, what she's looking at is trying to identify whether there are parts of the brain that can be activated differentially in people with misophonia compared to people who are highly emotionally dysregulated, but not by misophonic triggers. So she's looking to kind of figure out, where are the circuits in the brain? Where are those things? Where are they? Where are the ones we need to stimulate with a neurostimulation intervention? And is there any promise in using neurostimulation by targeting those circuits to decrease reactivity to triggers? So that's a promising angle. It's brand new. It will not be definitive. No matter what she finds, it will not be definitive. And she should be done with the data collection pretty soon. No pressure, Andrada, if you're listening. But she should be done soon. But the other two treatments we're developing are CBT-based psychotherapies. One of them is a process-based CBT, which provides a very flexible, brief, personalized approach that's essentially asks people to figure out what are the patterns before, during, and after being triggered. What are the patterns across areas of attention, cognition, behavior, communication, and physiology? And if you're paying attention to all that, I just made a grid for you. You've got before, during, and after as 3 columns, and then you've got these 5 systems as rows. And what we do is work with the patient to figure out where are the patterns in this matrix of potential patterns. Where are the patterns that are there that are problematic? And then amongst them, what are the most impairing, most distressing, and what are the patterns that they're most willing and motivated to work on? So we find the patterns, and then we figure out how to prioritize the patterns. And once we've got those prioritized patterns, then what we do is we use evidence-based processes of change that work for people, that generally speaking have been shown across countless studies to work for all sorts of different types of people to help with those particular patterns. Not in misophonia, but in lots of people. So if it's hopelessness after being triggered, we're going to use interventions that we know can work to decrease hopelessness in general. And we're going to let the patient choose to tell us, do they want to use intervention A or intervention B? If both intervention A and B have been shown to work equally well for something like hopelessness. It's the patient's choice. It's what we call a shared decision-making model. It's highly collaborative. They get to decide. We'll guide. If they want, we can, of course, tell them what we might recommend. But at the end of the day, this is a process-based treatment that's highly flexible and is not constrained by a brand name of a treatment. It's constrained by what has the scientific data shown works in general to change these fundamental processes. So I mentioned hopelessness as one, but you can kind of imagine this grid with these different patterns. You have physiological overreactivity. You have ways of thinking, like rumination, like judging yourself, like feelings like shame and thoughts related to guilt that can all be part of this. You have aggression, you have escape behavior, you have avoidance behavior, all sorts of different things that you can sort of imagine for any given patient will populate this grid of patterns that are then prioritized. And the interventions we choose all can work. We're just going to sequence them based on the priorities that the patient has. And we're doing this as a 16-week treatment, but it could be done shorter or longer. And then the other approach is what we call the unified protocol. This is a treatment that's for a wide variety of people with emotional disorders, and its focus is on emotion and really targeting emotional processes using a combination of evidence-based interventions. It's also very applicable widely to a lot of different types of people with lots of different kinds of problems, but it's more sequential in how we deliver it. Session 1, 2, 3, 4, 5, you do certain things. Whereas in the process-based approach, there's just a bit more flexibility and tailoring to the person. So those are the treatments that we're playing with and studying, and it's new and we don't have any definitive answers, but I can tell you both of those treatments are working for some people. We're collecting data and we'll be excited to share those data for the public sometime soon. So
you mentioned Andrada's study, which is looking more at circuitry. Can you tell us anything that you know about the brain basis of misophonia, if they have different brains than others?
Yeah, it's an awesome question, Jacqueline. There are some people that are much more educated about neuroimaging and much smarter than I am about that kind of stuff that could answer this question probably the best. But I'll give you the quick version that I can offer, which is that the brains of people with misophonia do appear to function differently than those who don't have misophonia in response to trigger sounds. There are a couple of studies that have shown this and have replicated that this is generally speaking, a true thing. In other words, this is not being made up. This is real. This is the thing. Now, where the particular circuitry dysfunction lies has varied in these different studies. A couple of studies have found that it's the emotional centers and emotional systems of the brain that are connected to the auditory centers, and it's that highway between auditory and emotion that seems to be implicated. Other findings suggest that it might be the sense of what's going on inside of our body, that sort of what we call interoception, that sense of what is going on inside of it. Is something wrong? Is something happening here? Is something not quite right with what's happening in my body or with my body? Other studies, in fact, a recent study that just came out, really interesting, found that trigger sounds in people with misophonia differentially activate the circuits of the brain that are associated with mirror neuron activation in response to people eating or making facial or oral movements. So some of you may relate to this if you've ever been around babies, and babies are, you're sitting there with the baby and you're feeding the baby, and you go to stick that spoon in the baby's mouth, and you lean in, and baby opens its mouth, and you notice you're opening your mouth too. Now, if this has never happened to you, you're thinking, he's crazy, what is he talking about? But trust me, this is a thing. This happens too sometimes. It's happened with me, with my kids. There are parts of our brain that are responsible for kind of these mirror-like reactions to others that are automatic, meaning we're not consciously trying to do it. And this study found that one of those parts of our brain that helps make those things happen is really highly activated. So it's actually really interesting. It suggests there might be a motor basis for misophonia, not just a kind of emotion and kind of auditory and visual basis. And by the way, visual is important too. Some of the brain research has showed that the visual parts, the parts of our brain that manage our visual input and the way they connect to our emotional centers also are part of this sort of trigger response in the brain. The bottom line is, A, there's only a few studies, so we don't know, and B, the brains of people with misophonia do appear to be functioning a bit different. But we need a lot more research on this to really be able to say conclusively anything about your question.
Cool. Well, Asan, thank you so much for coming on. I know this is going to be a popular topic because so many people struggle with this and they don't even know that there are others around who are going through the exact same thing. And that's been, I think, one of my favorite parts of this is just letting people know that they're not alone. And so...
Yeah, it feels incredible to be part of kind of the frontier of this knowledge and this ability to help people feel understood and feel not alone and feel empowered to try to understand more what they can do. It feels, as a clinician and as a scientist, as an advocate, it feels incredible. It really feels good. And there's so much more work to be done, though. That's the reality is there's just so much more work to be done. Here's the thing I'll leave you with, and then I'll hop off here. Try this and encourage your listeners to try this. Talk to someone, anyone in your life, about this thing you just learned about called misophonia. Describe it in your own words and see what their reaction is. My bet, and you can email me and you can tell me if I was right or wrong. I'm happy to take your email, but my bet is that almost everyone you talk to, when you tell them what misophonia is, they will say, "Oh my gosh, I know someone who has that." And they won't be talking about I just generally don't like the sound of people doing gross things. It won't be that. They will say, "I know someone," or it'll be them. It'll be a family member, it'll be a partner, it'll be them, it'll be someone. Most people will tell you, once you give them the name, that this is something that they've seen in their life. That's the challenge. That's the challenge I've given to you and your listeners. Check it out and report back.
That has also been my experience, so I'm willing to take that bet as well. Zach, thank you so much, and I don't know, we'll see you on Tuesday.
All right. Much love to you both. I love what you're doing. Yeah. See you soon.
Thank you. Bye.
Thanks, Zach.
Bye.
All right, well, I'm glad he finally admitted to us in the recording that he loves us too, and that we are his favorite podcast hosts.
Did he say that, or did we imagine
No,
it?
I added the second part. He said
Great,
much
great.
love, right, which I'm interpreting to mean more than just much love.
That was great. I always love having Zach on this podcast because he knows so much about all these different topics like borderline personality disorder and misophonia and all the cool emotional things. So he, it was really nice that he came on and talked to us about this. And it's really exciting because this is really there's so much opportunity for research and better understanding and treatments. And so I don't know. The part of this podcast is just get the word out so more people can either identify with it or talk about it or reach out to us with, like questions and personal stories. So, but Jacqueline, since you're a veteran in this, the CEMR Center of Misophonia and Emotion Regulation Center, can you tell us some resources or?
Yeah, I would go to the CEMR's website, which is this Center for Misophonia and Emotion Regulation that we keep mentioning. And that is just www.misophonia.duke.edu. And if you do want to email Zach to tell him how it went when you talk to strangers, his email is actually Mark with a K, mark.rosenthal@duke.edu. So I know he'd be tickled if people reached out to him from this podcast. Okay, so yeah, if you go to the CEMR website, you will see research, you'll see, our team, our approach to care, you'll see how we evaluate, but I think really just going to the website and seeing the research that's being done can be really helpful. And there are support groups, I believe, on Facebook and Reddit that you can search out as well to know that you're not, really not alone, like seriously. So that's all from us, and we will see you next week. By accessing this podcast, I acknowledge that the hosts of this podcast make no warranty, guarantee, or representation as to the accuracy or sufficiency of the information featured in this podcast. The information, opinions, and recommendations presented in this podcast are for general information only, and any reliance on the information provided in this podcast is done at your own risk. This podcast and any and all content or services available on or through this podcast are provided for general, non-commercial informational purposes only and do not constitute the practice of medical or any other professional judgment, advice, diagnosis, or treatment, and should not be considered or used as a substitute for the independent professional judgment, advice, diagnosis, or treatment of a duly licensed and qualified healthcare provider. In case of a medical emergency, you should immediately call 911. The hosts do not endorse, approve, recommend, or certify any information, product, process, service, or organization presented or mentioned in this podcast, and information from this podcast should not be referenced in any way to imply such approval.